Bismillahirrahmanirrahim. I'm Dr. Asim from Pathology Department. Today we'll discuss hypothyroidism, which is a fairly common disease in our population. Uh, we'll discuss about the pathogenesis, sign and symptoms of hypothyroidism, and we'll discuss about the differences between the cretinism and mixed edema, how they are diagnosed. Then more importantly, we'll discuss about the lab diagnosis of hypothyroidism, which tests are used for its confirmation. Hypothyroidism is caused by any structural or the functional derangement that interferes with the production of adequate levels of thyroid hormones. It is fairly common disorder, and by some estimates, the population prevalence of the overt hypothyroidism is 0.3% worldwide, and subclinical hyperthyroidism is more than 4%. Subclinical means there are no symptoms in that, but patient is having biochemical abnormality and sign and symptoms may not be present. In Pakistan, hypothyroidism has been reported to be about 4%. Its prevalence increases with age and is nearly tenfold more common in women than men. As in the case of the hyperthyroidism, this disorder, hypothyroidism, is divided into primary and secondary categories, depending on whether the hypothyroidism arises from an intrinsic abnormality in the thyroid itself or occurs as a result of the pituitary and hypothalamic diseases. Primary hypothyroidism can be congenital, acquired, or autoimmune. The most common is the post-ablative hypothyroidism, which is due to the surgery. And autoimmune hypothyroidism is also fairly common. It is under the heading of the thyroiditis, which will be discussed. It is associated with the enlargement of the gland, which is called gyrus hypothyroidism, Hashimoto's, and post-ablative hypothyroidism account for the majority of the cases of the hypothyroidism. Acquired hypothyroidism can be caused by the surgical procedures for the thyroid. A large resection of thyroid gland, like total thyroidectomy, for the treatment of hyperthyroidism of a primary neoplasm, it can lead to hypothyroidism. Then it is more common in areas where there is iodine deficiency or like use of the drugs methimazole and propylthiouracil, lithium iodates. Then there may be some congenital biosynthetic defects, which is called dysharmonogenic genetic goiter. The secondary causes, as I said, it may be due to some tumors or it may be present in the dysfunctioning of the pituitary or pituitary failure or the hypothalamic failure. The symptoms are just due to the metabolism, impaired metabolism. In hyperthyroidism, the patient is hypermetabolic, but in this, patient is slow. Metabolism is slow. He may be tired, lethargic, fatigue, and he may gain weight. There may be a lot of psychological symptoms like depression and mood swings. That in hyperthyroidism, heat intolerance is impaired, and in this, cold intolerance, dry skin, and hoarse voice. These are the common features which may be present when a patient presents in the OPD for his or her complaints. Then signs may be dry skin, thin hair, cold peripheries, puffy face, which is a common and you can typically diagnose from the features, and with their slow reflexes. There may be bradycardia, there may be peripheral edema, reflexes will be slow, ataxia, dementia, and psychosis. These are all signs of the hypothyroidism, which may be present in all may be present in one patient, or there may be some present, and depending on the stage of the disease, there may be presence of the some features, and later on all may develop if it is not treated properly. Cretinism is basically develops in infancy or early childhood. It refers to the hypothyroidism that develops in infancy or early childhood. In the past, this disorder occurred fairly commonly in areas of the world where dietary iodine deficiency was endemic, such as Himalayas, inland China, Africa, and other mountainous areas. Iodine deficient areas, impaired development. This is the one disorder in which we can treat the patient just by early diagnosis and delay all these features. If it is properly diagnosed at the time of the birth, then we can delay all these abnormalities like mental retardation, and he can pass normal life just by giving one tablet. So, diagnosis of cretinism is very important for the children who are undiagnosed at the time of the birth or later on, and they are not properly screened for that one. Cretinism, hypothyroidism presenting with the mental retardation, short stature, characteristic puffy appearance of the face, hands, and frequently deaf mutism. They are unable to hear or speak also. There may be respiratory difficulty like cyanosis, jaundice, poor feeding, hoarse cry, umbilical hernia, and marked retardation of the bone maturation. These are all the features present which may be present, and the issue is of its diagnosis. If there is a family history of thyroid disorder in the family and a child is born, he must be screened. Rather, every child should be screened, must be screened. Now, there are laws outside in other countries that every child is screened for this disorder because by this diagnosis, we can prevent a patient getting into the delayed mental maturity and other signs and symptoms of cretinism. Cretinism, like macroglossia, tongue is protruding from outside its big tongue, severe learning disability, patient is unable to learn, short stature, protuberant abdomen, and pubertal developmental delay, umbilical hernia. These are the symptoms, signs which can be present, and if these can all be reverted if it is diagnosed properly at the time of the birth or in the first year of the life. This is the pallor, dry skin, and umbilical hernia, typical feature of the hypothyroidism. Again, you see, this is macroglossia, look, very dull look of the patient, and mental retardation. We can diagnose the case by just keeping in mind this picture. Screening for the congenital hypothyroidism or cretinism is very important. There are two different schemes which are used, but in Pakistan, unfortunately, it is not regularly practiced. In some centers, it is done, but it is not by law. In other countries, it is by law to screen the children for other inherited metabolic disorders, but particularly for the cretinism, because we can just give one tablet for the treatment of this patient and patient can have a normal life. Specimen is collected about 2 to 3 days after birth, and there are two screening strategies. One is either you measure the T4 and it is backed up by the TSH. T4 is measured initially, and if T4 is low, then TSH is measured. If TSH is more than 30, congenital hyperthyroidism is confirmed. If it is borderline 20 to 30, then it is recalled for the repeat testing. Now, this thing is mandatory. Every child born in the hospital or in the other setups, they are they are called upon for checking of these tests by just one prick from the heel and get the blood and get the test done. Second strategy or approach is, which is more sensitive and specific. This is a Guthrie card. You have to just place the one drop over the card, and it is sent to the main central lab for the diagnosis. And along with this cretinism, there are many other disorders which can be diagnosed, and this is mandatory for all the children to be screened for inherited metabolic disorders at the time of their birth, which can be diagnosed. In this TSH approach, if it is more than 30 million international unit, then congenital hypothyroidism is confirmed. If it is again between the borderline, then T4 is measured. If it is less than 65, we call for the repeat testing. It means they follow the patient so that he may not at any stage of his childhood develop the cretinism, which will definitely retard his mental development. Mixed edema is basically in older children or adults. In older children means the symptoms may be like this, but not the same one as it is present in the children. They show signs and symptoms intermediate between those of the cretinism and those of the adult with the hypothyroidism. Clinical manifestation vary with the age. In the adult, the condition appears insidiously and may take years to reach the level of the clinical suspicion. It means clinical suspicion will be present when the signs and symptoms are present, but the patient is definitely passing through the hypothyroidism. That is called, his biochemical levels will be abnormal, but clinically they are not so apparent. That is called subclinical hypothyroidism. Signs and symptoms are just opposite to the hyperthyroidism, like slowing of the physical and the mental activity. You may be remembering in that patient is overconscious, anxious, hyperactive. Here the patient is listless, cold intolerant, overweight, constipation decreased, reduced cardiac output and decreased exercise capacity, hypercholesterolemia and low LDL and accumulation of the matrix substances. These are the signs and symptoms of hypothyroidism in the adult. Now look at the picture. A patient looking like very lethargic, listless, indifferent, and skin is coarse, and the tongue is like protruding like this, and it is tongue is enlarged, and gives a typical picture of that one. If you look at this picture, patient is overweight, patient looks like very slow, her reflexes will be very weak. These are the signs and symptoms which you must keep in mind when you see the patient in the OPD, then it must give you a look. Rather than giving when you take the history, there may be all the symptoms present in that. Now, if there is a suspicion of hypothyroidism, along with these symptoms like unexplained increase in the body weight, lethargy, patient is unable to move, very slow, reflexes are slow, responds slowly to the commands, hypercholesterolemia, then go for the TSH level. It is a sensitive screening test. What will be the level of TSH? In hyperthyroidism, it is decreased, and in hypothyroidism, it is increased. Please remember this one. This is very important. Mostly students present the reverse picture. Increased hyperthyroidism, it is decreased. In hypothyroidism, it is increased. Now, 57 years old woman consulted a general practitioner because of the weight gain, constipation, and weakness. These are the vague symptoms. These may be present due to some other conditions also. Then, if you have a suspicion, she's a woman and having these symptoms, then thyroid function should be advised. Her TSH was 54, normal is up to 5. Free T4, which is more sensitive, 5.7, and it is low as compared to the normal reference rate. What other test can be performed for the confirmation? Can you guess? Yes, we can go for the autoantibodies, anti-TPO, which is an important component of the diagnosis. Although it is confirmed on this one, and along with the symptoms and these levels, we can definitely go for the antibodies. In the next lecture, we'll discuss the thyroiditis and neoplasms of the thyroid gland. And after that, about 8 or 10 scenarios will be discussed regarding the thyroid in one lecture. Thank you very much.